Hello everybody, I'm Dr. Neha Bothra and this is a video of a very challenging surgery that we completed about a week back. I'll begin with a disclaimer. This is a fairly long video, but while editing it, I realized that there were scarcely a few minutes that I could cut down here and there, and every step of the surgery was very important and very interesting to review. And I have kept most of the surgical steps in order to demonstrate how we completed this challenging surgery. Also, this video will be more interesting for surgeons than for patients or non-medical personnel, but everybody is welcome to view and enjoy. So let me begin with a brief history of this patient. She is about a 55-year-old woman who had undergone an open abdominal hysterectomy about 4 or 5 years back. Her tubes and ovaries had been retained at that time, and she had presented to us with severe right-sided flank pain. The pain had been gradually increasing for about a day or two, and it mimicked a typical ureteric colic or pain that we see in ureteric stones. An ultrasound showed a Hydrosalpinx, and we did a CT in order to rule out any other findings that we would have suspected, but nothing came of it, and her pain was persistent. So we went ahead with a laparoscopy. On laparoscopy, as you can see, right from the beginning, the pelvis was completely plastered with bowel adhesions. We could not even see the vault at this point. And we were, to be very frank, quite flummoxed that how to begin with this surgery. But as is the principle, we begin with what we can see, and we try to move from the healthy tissue in order to reach the diseased portion of the pelvis. So right here I'm trying to find some kind of plane in between the pelvic wall and the bowel, and here I see my first ray of hope, where a flimsy adhesion has given way and I can find some window into the lower pelvis, and between that I'm starting to find a plane of dissection in order to dissect the bowel away from the pelvic wall, from the vault and the pouch of Douglas. Now, this kind of surgery is particularly challenging because all the surgical planes are very, very close to the bowel. And because of that, let me be very honest, this is something that requires more than one pair of eyes. So with me on the assistant end is Dr. Himani Sharma, and our resident Dr. Kiran is on the vaginal end. I'm constantly asking Dr. Kiran to try and demarcate the vault for me while I'm doing this dissection, but it's not really successful because, as you can see, the urinary bladder is overhanging over it along with the bowel, and I'm not able to find a plane there right now. So I move my dissection to another portion of the pelvis, and this is the point I would like to highlight here. In women who have had past pelvic surgeries, especially hysterectomies, the familiar landmarks that we as surgeons are used to are lost, like the uterosacral ligaments, the infundibulopelvic ligaments. Once they are cut off, they completely retract towards the pelvic wall. And the round ligament is the one point that still remains, which we can identify and where we do often find a plane of dissection. So here, as you can see, beginning from that point of the right side round ligament, I am able to find some plane by a combination of a blunt dissection and sharp dissection in order to dissect the bowel away from the pelvic wall and find some window on the right. Now, when we are talking about dissection, it is always a combination of sharp dissection and judicious blunt dissection, because around the bowel we try to use minimal thermal energy and stick to sharp dissection as much as possible. The retraction offered by the assistant is also very important, because it is not just retraction, it has to be retracted in a specific direction, and the direction needs to constantly change along with the direction in which we are able to continue the plane or finding the plane of the adhesions. Now, after continuing the dissection on the right, I am again attempting to reach the vault. As you can see here, the vault is still covered by the overhanging urinary bladder, and I move on to the left side round ligament, which is being demarcated right now by stretching the bowel over it and beginning with sharp dissection there. Now, as you can see, there are a few hesitant cuts that I am making judiciously over the lateral pelvic wall and trying to dissect the bowel away from there. This is a retroperitoneal space. It is with many important structures, and dissecting there has to be done very, very carefully and very judiciously. Around this point in the surgery, I was frankly a little unsure if I would be able to complete this at all, because finding the planes and doing all the right thing was not leading to much. And as you can very well see, I have not yet seen either ovary or either tube with the Hydrosalpinx. And again, identifying the vault by tactile reception, I'm trying to demarcate it by feeling the resistance that the sponge holder is giving, and it is trying to find a needle in a haystack right now for me. But fortunately, right at this point, I found some plane between the vault and the bowel, and the bowel thankfully retracted, and I was able to find a small window where I could again begin the dissection. Now, sharp dissection, blunt dissection is continued for some time, and the small bowel loops are getting retracted away from the pelvis slowly and steadily. Having good instruments, sharp curved scissors is also critical, because we cannot make too many cuts or hesitant cuts over this, and finding the right plane is very, very crucial. Gently using blunt dissection also is helping in peeling away the bowel away from the pelvis. What I have held in my hand is actually the bladder. The vault is further below this, and I am just right now feeling it by tactile sensation and haptic feedback in order to feel where exactly the vault is and where I am dissecting, because the bowel is going away, but I have not yet seen the Hydrosalpinx and the ovaries. But there is slow and steady progress, and I am able to dissect the bowel loops away. Now, because the bowel is stuck, and in spite of a lot of head-low position, the upper bowel is also not getting retracted, and that is also hampering our vision slightly. Because we are using 3 ports, in spite of that, the bowel is again and again coming back into the pelvis, and we have to be very sure, we have to keep all our instruments in view so that we do not inadvertently damage some bowel off screen, which is something we always have to be careful about whenever we have sharp instruments and thermal energy instruments within the abdomen. When it comes to complicated surgeries and when it comes to different googly cases, it does help to change your field of work once in a while. Our eyes, our mind gets little exhausted from doing the same thing in the same place. So you will find me slowly working on the right and then coming back to the left, then again going back to the right of the pelvis in order to get a fresh view after a while, and to come back after working on the other side slowly, so that I can be refreshed and I can see it with a fresh mind after a few minutes. Again, trying to peel away the bladder from the vault. So the white shiny globular portion on the left is definitely the vault. There is no bladder between that and the pelvis, but I am not yet able to reach the tubes. Now the round ligament, as I mentioned before, is a reliable indicator, and I am trying to dissect around it. And here finally I would like to call it, there is some window of hope where I finally am able to see the ovary and the hydrosalpinx that is finally revealed to me. Now, keeping that as a marker, and with new ray of hope, I begin dissection, and I'm peeling away the flimsy adhesions between the pouch of Douglas and the little bowel that is left behind stuck to it. So there is a pocket of no adhesions, and the bowel is strictly adherent only to the vault. As you can see, the pouch of Douglas is fairly free, and I can see the left ovary and the right ovary with the bluish glistening hydrosalpinx on the right. I'm trying to separate the hydrosalpinx as much as possible by sharp dissection, and there are still quite tough bowel adhesions on the hydrosalpinx itself. It is not freely hanging, that itself is adherent. Now the left ovary is seen, but I am not yet able to find the left hydrosalpinx, and here our keen eye is very important, because beneath all this fat and beneath all this I would say mesh of loose areolar tissue, we could identify what was the hydrosalpinx, and I started dissecting around it. So our eyes and our feel that we get back from the instrument, which is our haptic feedback, that helps in guiding our dissection. I can see that some fat and some physiological adhesions which are present of the sigmoid loop, they have to be dissected out in order to reveal the hydrosalpinx, but they are not too much in the way. So I will not be doing that extensively, and I will focus my attention over to the hydrosalpinx itself. The left side hydrosalpinx was particularly adherent, especially because we have the sigmoid and we have the sigmoid mesocolon, which arises from the left side pelvic wall. So naturally that portion is going to have more adhesions, and I had to really peel off the flimsy adhesions there. But as you can see, it, in spite of quite a good bit of traction, it is not coming out of the ovarian fossa or the pelvic side wall. So because of that, and I was trying not to puncture the hydrosalpinx. Once we puncture a cystic structure, it starts coming out in bits and pieces, which is what I did not want to do at that point. And I was trying to peel off the flimsy adhesions over it, but the scissors were not working at that point. And then in a few seconds, you will see, I decided to move on with taking up the quite trusted suction cannula, and that did the trick at that place. Because this was a delicate structure and I did not want to puncture it, I decided to get rid of the scissor and take a suction cannula in order to dissect around the hydrosalpinx. Now, the suction cannula does beautiful blunt dissection. We use it for dissecting the bladder of the vaginal vault and such delicate dissection. When used judiciously and when used with low suction and with good amount of judicious traction, it is a very good instrument for dissecting around flimsy adhesions and the likes. So the suction cannula seems to have done the trick for here, and I'm able to extract the hydrosalpinx on the left side out of the fossa where it has got nicely stuck. Changing the point where I'm holding the hydrosalpinx and changing the direction of traction, the force of traction reveals that the hydrosalpinx is quite large. For that matter, it's about 4 and 5 centimeters, but it is now come out of where it is stuck, and I will just have to desiccate and cut its pedicle. The ovary on this side does not seem to be free at all, and I will look into that part later. Coming back to the hydrosalpinx on the right, this is larger and it is stuck to the bowel on the right. So I decided to go ahead with a right-sided salpingo-oophorectomy. Now, as you can see here, this right hydrosalpinx is tense, it is contorted, it has undergone torsion, and that is obviously the cause of the pain that the patient had over the past 2 days. So unfortunately, in the open hysterectomy, she did not get a salpingectomy also done. It might have been some old school of thought because of which this was not done, but it did come back and trouble her at this point. Now, for desiccation and cutting, especially vascular pedicles, ligature is the instrument that I trust, and because it was very close to the bowel loops around it, the insulated tip of the ligature is very safe, and the right direction and desiccation at 2 or 3 points followed by cutting is doing the job here. So I am desiccating and cutting the infundibulopelvic ligament on the right side, and the twisted pedicle is still quite stuck. It is requiring quite a bit of force of traction in order to pull it out of the lateral pelvic wall into a safe space where I can desiccate and cut it away from all the bowel that is adherent on its right. It kept twisting and turning, but finding the right plane and cutting made it freer and freer so that I could remove the right tube and ovary after this. I think viewers will be able to appreciate the amount of traction that I have to apply here, because this is a stuck structure. It is a repeat surgery, and all the inflammation that has occurred over the many years post surgery has made all these changes and all this surgery all the more difficult. But in a few more steps, the right tube and ovary will be out, and I will be addressing the left hydrosalpinx. I remember my teachers during residency always warning us that post-hysterectomy laparoscopy is a particularly difficult surgery, and that just kept ringing in my ears throughout the surgery, that it might be one of the few times that I did encounter this, but it was very heartening for me that at least I was able to reach here and complete it in spite of all the challenges. And all the surgical principles that we have learned throughout the years were used, each and every one of them, in order to complete this surgery. Now, once the right side hydrosalpinx is out, I address the left side hydrosalpinx, and the same instrument, the ligashore, is used here for desiccating and cutting it. As I said before, on the left side, the sigmoid, the ureter, the great vessels, they are all quite close to the pelvic wall and where we are operating. And we had to be very careful about what we are desiccating, what we are cutting, making sure that there are no vital structures within that. Here, the tubo-ovarian ligament, the ligament connecting the hydrosalpinx with the ovary, is cut, and that frees it up quite a bit, giving good traction here, releases it and pulls it away from all the vital structures that we do not want to damage while removing the hydrosalpinx. Now, as I said before, this ovary was quite stuck. It was completely plastered to the left pelvic wall, and removing it and dissecting it would have required a complete dissection of the ureter, uretrolysis, and that did not seem necessary, so we did not go ahead with it. Now, as a standard, we removed both the specimens in an endo bag and extracted it by enlarging the left lower port. We did not remove it from the 10 mm umbilical port because the ovary would have been difficult to remove without viewing it. The specimen is removed from the left lower port, as you can see, and after that we placed an interseed over the pelvis and all the raw area because we did not want this episode to be repeated. The left lower port was then sutured with a figure of 8 suture in order to prevent any hernia. Thank you for watching.